Hello everyone, my name is Alkhayat and I'm a general surgery resident in the Kuwaiti board. Welcome to the General Club. Today we have an interesting article that may change the way you view or even approach attention pneumothorax. According to the 9th edition ATLS guidelines, the treatment was needle decompression in the second intercostal space mid-clavicular line. Let's see if by the end of this video we change your view. In this study, the authors aimed to compare anatomical location in needle decompression by two outcomes. Firstly, by chest wall thickness, and secondly, by defining the failure rate of needle decompression. The main goal of this study is to define the optimal location of needle decompression. So why is this important? There has been debate in the past that this may not be the ideal location for many different reasons. What the authors mentioned though is that even though this is a well-known landmark and a common question to medical students, it is frequently misidentified and actually more often identified in the trauma box, which may lead to vital structure injury. Well, how was the study done? They had an experienced librarian design and conduct a search strategy from several databases using a clear criteria. For measurement of chest wall thickness, they included all articles that either used a CT or directly measured it on cadavers, and excluded any that used ultrasound based on variability. Regarding decompression failure rate, they included only studies that used a 5 cm needle following the 9th edition ATLS guidelines, and excluded if any other length was used. They've then displayed their search strategy on a flow diagram, detailing each step along the way and ending with 15 articles for chest wall thickness and 13 articles for needle decompression failure rate. They've also discussed reasons for articles excluded in a later segment. As for the results, for chest wall thickness, it was thickest at the second intercostal space, mid-clavicular line, thinner at the fifth intercostal space, mid-axillary line, and thinnest at the fifth intercostal space, anterior axillary line, with a p-value of 0.08. Regarding decompression failure rate, it was highest at the mid-clavicular line, lower at the mid-axillary line, and lowest at the anterior axillary line, with a p-value of 0.01. They also had a secondary outcome where chest wall thickness was compared by gender, and they noted that women had higher thickness at both the mid-clavicular and mid-axillary line, with a p-value of 0.02 and 0.01 respectively. However, there were no studies comparing chest wall thickness by gender at the anterior axillary line. They have then demonstrated these data on a forest plot, as can be seen here. Then the authors went on to discuss many factors considering anatomic site, needle length, and safety if a longer needle was used. But in the end, they've concluded that needle decompression may be more effective if used at the 4th, 5th intercostal space, at the anterior axillary line or middle axillary line, rather than the recommendation at the time. And now, analyzing the study, we can clearly note its strengths. To start, it's a systematic review and a meta-analysis following their respective guidelines, and they did conduct a comprehensive search in the process, including all articles available. However, having said that, it's not free from weaknesses. I would like to emphasize on 3 points specifically. Firstly, they did not inquire about relevant unpublished studies. This might have led to publication bias. Secondly, they did not assess if heterogeneity was significant, but they quantified it using the I-square test, which actually showed that the results was highly heterogeneous. And more importantly though, they did not explore reasons for heterogeneity. Lastly, the results might have been affected when they combined the results of the 4th and 5th intercostal space at the same anatomical line, although the authors countered that it was not statistically significant. To conclude, this is a relatively well-designed study, with its own limitation of course. Nonetheless, it added valuable perspective and awareness to the limitation of needle decompression under guidelines at the time, with the data justifying their conclusion. And now, for the most important question, would I use it in my current practice? I would say, currently, the 10th edition of ATLS has been updated to recommend the insertion of an 8 cm needle in the fifth intercostal space, anterior to the mid-axillary line. So clearly, I will. Thank you for watching. Leave your comments in the section below. Like, share, and follow.